Now coming to two important disorders which are clinically very important. Now we are done with our nervous system also and muscular system also. There is some group of disorders which is happening in between them. That is the neuromuscular disorders. This neuromuscular junction is the junction between a neuron and a muscle. Here the above one is a neuron and a muscle. So what happens normally? First we will understand the normal. So whenever the action potential arises, for example, the sodium is bringing in the action potential, they will come and reach the nerve terminal. Whenever the action potential reaches the nerve terminal, there will be activation of one more channel which is called as calcium channel. Voltage sensitive calcium channel will get activated. So what the calcium will do? The calcium will enter into the neuromuscular junction, that is the neuron terminal, and they will cause fusion of vesicles and they will throw out their products. What is this products called? A process called as exocytosis. It is a type of active transport, the vesicular transport, and it is a type of active transport. So once exocytosis happen in a neuromuscular junction, what is the neurotransmitter release? The neurotransmitter released is acetylcholine, ACH, and the muscle will have some receptors which is called as acetylcholine receptors. So this is nothing but our acetylcholine receptors. Now let's understand these two diseases. Where is the defect exactly and what will be the symptom of presentation, what is the treatment. So coming to the first disease, that is Myasthenia gravis, and the second disease is Lambert Eaton myasthenic syndrome. Most of their features are overlapping, so even in the history sometimes it will be difficult to find it, but we'll try to pick out the points which differentiates them very nicely. So what happens in Myasthenia gravis? In Myasthenia gravis, there are antibodies against the acetylcholine receptors. So what is happening here? It is a postsynaptic problem. There is a muscle and these receptors are there and there is an antibody production against these receptors. So what will happen? Even though the acetylcholine is released from the presynaptic terminal, what will happen? They cannot go and bind with the neuromuscular junction and they cannot perform their action. So what is the predominant features of this myasthenia gravis? There is paralysis of ocular muscles. The ocular muscles are mostly affected and it will cause ptosis. And there will be obviously muscle weakness. So these are the two important features. Now let's come to the Lambert Eaton syndrome. Lambert Eaton syndrome, what is the issue is, there is a problem with the PQ type calcium channels. PQ type calcium channels. Why? What is the function of this calcium channels? This PQ type calcium channels has to enter the calcium first, has to send in the calcium first. As you can see here, this area, they have to give the calcium first for the vesicle to be fused and released. If calcium itself is not entering, then the acetylcholine amount itself, there is reduction in acetylcholine release. So that is the issue here. So what is the problem in Lambert Eaton syndrome? In Lambert Eaton syndrome also, the ocular muscles will be affected. But more than that, predominantly the proximal muscle group will be affected. What is proximal muscle group? Proximal to the body. This away from the body is called distal. So proximal to the body, whichever is there, those muscles will be affected. But here also ptosis will be there. I told you, with if ptosis is given in the question, we cannot differentiate it because both of them can have ptosis and both of them will have muscle weakness. So with these features, we cannot differentiate between the two disorders. So we have to study a little more features to understand the difference. Here, in case of myasthenia gravis, the reflexes are not affected. This is one clue which you can get. When they say the reflexes are not, the reflexes are present, then it is more in favor of a myasthenic gravis. Whereas the reflexes are sluggish in case of a Lambert Eaton syndrome. The reflexes are sluggish in case of a Lambert Eaton syndrome. But more than that, one very important clue will be there, that is autonomic dysfunction. Autonomic dysfunction like dry mouth and impotency, if it is given in the question, then it is most likely a Lambert Eaton syndrome, because this is not at all present in case of a myasthenia gravis. Then what happens? The symptom worsens as the day progresses. In case of myasthenia, this is another important clue. The symptom worsens as the day progresses. Whenever the person is getting up from the bed, what will happen? The symptom is not that much. But whenever he is going through the day, towards the evening, his symptoms are worsening. What could be the reason? Because let's take in him, what happens is, whenever he wakes up from the bed, let's say 100 receptors are normal. This is arbitrary numbers. And as and when he starts to working, what will happen? These receptors are getting used up. They are also getting fatigued. So their neurotransmitter release and their binding with neurotransmitter goes down. And his number is already less because rest everything will be blocked with the help of blocked by the antibodies. So as the day progresses, the receptors are getting used up and he will feel weak. Whereas in case of Lambert Eaton, the reverse happens. In the evening, he gets better. What is the reason behind it? Because of repeated stimulation, whatever calcium channels are available, not don't think that 100% of the calcium channels are gone. Whatever calcium channels are available, because of repeated stimulation, they can be kept open for a longer time. The calcium channels can be kept open for a longer time so that they can come and fuse with the they can activate the vesicles and send in the neurotransmitter. So this is another thing. So repeated stimulation, if I give, the fatigue will set in faster in case of a myasthenia gravis. Repeated high stimulus, low stimulus we are not giving, high stimulus only can elicit this reaction. The repeated high stimulation increases the response. It increases the response. So this is one major difference. So symptoms worsen, then it is mostly in favor of myasthenia gravis. Symptoms is getting better towards the evening, then it is in favor of Lambert Eaton. Then coming to one more association, that is the Lambert Eaton myasthenic syndrome association. It is strongly associated with small cell carcinoma of lung. Even the standard books write that even before the patient comes for a small cell carcinoma and even before the symptoms of small cell carcinoma is diagnosed, usually the patient presents with myasthenic syndrome first, like Lambert Eaton syndrome first. Lambert Eaton myasthenic syndrome comes first. Why? Because this carcinoma is subjected to produce the antibodies against the PQ type calcium channels. So these antibodies are produced by these cancer cells. So this feature starts to appear first. So in this patients, what we have to do, whenever you meet up a patient with LEMS and you confirm it is a diagnosis of LEMS, then always we have to look in for a small cell carcinoma of the lung by taking radiological images. So this is one important feature which is differentiated from the myasthenia gravis. Then what is the drug line treatment for it? Then we have some drugs called as neostigmine. And since it is an antibody mediated, we have to immunosuppress the person on a longer time. What is this neostigmine? Neostigmine is an acetylcholine esterase inhibitor. So how come this drug is helping? What happens is the neurotransmitter is released and the postsynaptic membrane is there. The acetylcholine is released. After the action of acetylcholine in a normal subject, in everybody, what happens is this acetylcholine is usually destroyed by acetylcholine esterase enzyme. So this acetylcholine esterase is destroying the acetylcholine. What if we destroy this acetylcholine esterase? Whatever acetylcholine is available, they can stay there for a little longer time, and whatever receptors are available in that person, they can get activated for a longer time. That's why this treatment is given. And even we can give it for the LEMS patient, because whatever acetylcholine is released from the available calcium channels, they can stay there for a longer time. This brings us to the end of the nerve muscle physiology. We'll see it in the next lectures. Thank you.